Do you want to know how to identify pain mechanisms and select the best approach for each individual? That's exactly what we are exploring today with Dr. Michael Maxwell. Dr. Maxwell is a chiropractor and educator passionate about making musculoskeletal care practical and evidence-based. He is Canada's only certified instructor for clinical neurodynamics and also teaches dynamic neuromuscular stabilization. With over 20 years of experience and having organized hundreds of continuing education courses, he brings a unique expertise in movement-based manual therapy and exercise. I'm Ariana Parks, a physical therapist, and this is the PT Pro Talk podcast, where leading clinicians share practical tips to improve your clinical practice. If you're new here, don't forget to subscribe and hit the like button so more colleagues can find this content and so you don't miss future episodes. Now let's dive into today's discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PT Pro Talk for a special offer. Hi, Michael. Welcome to PT Pro Talk. How are you today?
I'm doing great. How are you?
I'm doing good, thank you. And let's get started just talking a little bit about yourself and your background, your career.
Yeah. So what do you want to know?
Well, I know you have a lot of experience in a lot of different fields. So I know you do a lot of courses, continuing education, and just tell us how you got started in this area and how was the evolution over the years.
Yeah, I mean, I was always interested in the human body. I was kind of obsessed with exercise when I was quite young, probably as a result of the obsession overtrained quite a bit. Definitely got a few injuries on the way. So my interactions with healthcare providers were always intriguing to me. So, go back to when I was like 15, 16 years old, I knew that I was kind of interested in going in this direction in the field. Now at that age, I don't know that I knew that I was capable of getting to that degree of academic endeavor, but nonetheless, I was super intrigued in that profession and field. I started personal training when I was 17 years old. I had some really good mentorships along the way. So one of my first mentors was a kinesiologist. So someone, I don't know if you guys have kinesiologists there, but someone who specializes basically in exercise rehabilitation. He inspired me and was a great mentor. And from personal training onto medical exercise and corrective exercise into exercise rehabilitation and some performance related sport applications and strength and conditioning. And then I did my kinesiology degree, continued to work in that space until I went to chiropractic school. The bit, as you mentioned, the educational side of things, when I was in my undergrad or even before that, I was pretty keen on attending like workshops and courses. That's actually how I met some of my mentors along the way. Had been to a couple, personal training conferences and found them really inspiring and really enjoyed learning and attending them. So when I went to my undergrad, I was actually quite disappointed in the degree of like applicable or practical information that we got in that degree. It was pretty much, I would say 99% theory. And the practical stuff that we did do was primarily physiological. So, doing like a VO2 max test or something like that, Wingate test, et cetera, which was interesting, but it wasn't the applied biomechanics that I was really interested in. So I went to the dean of the faculty and I said, hey, what do you think about doing like a little like conference for students and bringing in presenters from around the community that could, offer some, practical labs and stuff like that. And he kind of very politically told me it was a great idea, but that I would have to go through a lot of barriers to make it happen. And at that point, I kind of decided that I would just start to host workshops on my own. So when I was going through my undergrad, I started to host workshops just kind of with like local people in the community that kind of excelled in their domain. And then after I finished my undergrad, I kind of decided to kind of step it up a notch and bring in like a presenter from the US to teach on like whiplash mechanisms, a fellow named Michael Freeman, who's MPH, PhD in DC. That went really well. And I thought, oh, that was great. So maybe I'll do some more of this. And My first year in chiropractic school, I put on organized four courses, kind of in the west coast of Canada, and then that went well. And I thought, oh, that was great. So the second year of school, I did, I think, 8 or 9 courses, and that went really well. My third year, I tried to do 24. I think I failed and ended up doing like 18 or 19. A few of them
Oh
had to
my
be
goodness.
canceled. But yeah, so this was all essentially why I was going to chiropractic school, that I was bringing in, people like, Jack Miller and Stu McGill and some big names in the chiropractic and physiotherapy professions like Chris Powers and people like that. So yeah, that's kind of my educational story. And then obviously, as I graduated from school, I continued to run that kind of continuing education business, and ultimately hosted somewhere around like 300 to 400 courses in a period of just over a decade. I've handed that company over to Benjamin Stevens now. So he now owns and operates that company fully. But I did that primarily so I could focus on teaching and creating content versus organizing courses. So that's where we are now.
Before we continue our conversation, I wanted to take a quick moment to present you to our sponsor, NeckCare.
Traditional neck assessment methods often fall short of providing a full picture, overlooking movement control and sensory motor integration. That's why a physical therapist developed the NeckCare system to provide reliable assessments of sensory motor integration, proprioception, and range of motion. With objective data and visual results, physical therapists can better understand neck impairments and design targeted treatment plans for optimal outcomes. If you treat neck impairment in your practice, visit neckcare.com to learn more.
And now, let's get back to our conversation. That's so cool. So, like, since the beginning, you're already exposed to so many different, people and, learning from different probably line of thoughts and techniques and different people. And
Yeah, well, something that I understood from a young age through my own injuries was that, you know, you can't really afford to pigeonhole yourself into it. This is my opinion anyways. Perhaps we shouldn't afford ourselves the luxury of pigeonholing ourselves into one technique or one system, because it doesn't take long for a patient to walk into the door that doesn't really fit that model. So as a patient with a pretty severe lumbar disc injury when I was 18, 19 years old, I experienced that firsthand. I experienced people who had a very specific idea of what they would do with me. Probably before I even walked into the room, they just had like a template in which they would follow for people with discogenic back pain. So I saw physiotherapists, kinesiologists, chiropractors, they all helped in their own way. But I found like I plateaued a lot. I'd get an adjustment, actually, ironically, from a physiotherapist, super helpful, pulling me out of that acute stage. And then I kind of plateaued with him. Was with him for another 3 months after that. Didn't really get a lot better after that first couple weeks where he was just giving me a couple adjustments, and then adjustments didn't really seem to help anymore. And the exercises that he was prescribing didn't seem to help either. Ended up seeing someone who specialized in active release technique. That actually helped a fair bit, but didn't really solve the problem entirely. So again, I plateaued, and then I saw someone who specialized in corrective exercise and rehabilitation, and they kind of added a layer. And then I saw someone who's, a structural integration, one of the teachers for Tom Myers in the anatomy trains. And, after seeing him, I felt like I was pretty close to, as resolved as you can be with that history of an injury. So, going through that process, I thought to myself, why did I have to see, 6 people over a period of a year and a half to find the solutions to my problems? Why couldn't that be, one person who had multiple different tools, and a broader scope in how they would look at, my injury, my function, et cetera. So, that was my experience as a patient. And I kind of felt like as a practitioner, I wanted to embody, the principle of being, diverse, have breadth, but also depth, in the work that I do. And I remember Clayton Skaggs, who was, he's not doing a lot of teaching anymore. He was one of the first chiropractors to go over to Prague and mentor. Well, I should say first chiropractors, one of the first North American practitioners to go over to Prague and do mentorship with Carol Levitt and Vladimir Yanda. He taught for me for a few years. And I remember him saying to me, he said, I'm going to not get the sentence exactly right. This was like, 18 years ago when he said this to me, but the sentiment was that he felt like expertise in an individual technique of manual therapy was overrated. That the breadth and knowing when to apply your skills was more important than being amazing at one given thing. And we were talking, in reference to manual therapy. And I kind of feel like that's true. I kind of feel like breadth is probably more important than depth. I do think that there's situations that violates that principle. So, for example, if someone has a very specific dysfunction of the foramen in which the trigeminal nerve exits, and there's some kind of an entrapment around that foramen as a result of cranial dysfunction, you know what I mean? Like, that's going to require a very specific skill set to address that problem, which most people don't have. So I appreciate the people who choose to specialize and choose to excel at one thing, cranial sacral therapy or whatever that might be. However, there is a ton of people that don't apply, like in chiropractic world, we've got upper cervical specialists, and the perception, at least, that you get from talking to those people is that they kind of feel like they can treat all people with that technique. And that's just simply not true. But there are some people who would have that dysfunction in which it might be really powerful for. My preference has been to go after breadth, and then from breadth find depth. So get a wide net, and then focus on being exceptional at each one of those domains that you're working in, and that takes obviously a career to do. So I was talking to a young chiropractor yesterday. Was it yesterday? No, day before yesterday. And I was saying to him, listen, like, I'm, what am I, 2007. So I'm 18 years. I'm in my 18th year of my chiropractic career. And of course, was practicing in the realm of strength conditioning, kinesiology before that. I still feel like I'm learning at a rate that is equivalent to what I was learning at when I was in year 1 or 2. Like, I don't feel like there's been like a down, shift in terms of the rate of learning. Of course, what I'm learning is different. And I'm layering on top of the past knowledge that I've acquired. But if you really want to seek it, I really don't think that there's an end to learning in the work that we do. And to be honest, like, the work that we do is really freaking hard. Like, it would be much easier to be a surgeon, like to just get really good at doing surgery on a shoulder or doing surgery on a spine like that. I feel like that's a lot easier than what we do, which is working with people with their own, set of goals and emotional characteristics and cognitive characteristics and socio-environmental factors and physical capabilities and, very unique nervous systems that sometimes just don't really respond the way a typical nervous system does to load. I've got a patient right now, and I'd seen her in the past for different injuries, just such an amazingly unique nervous system. So for example, we're doing a low oblique sit, which for those of you who don't know DNS, is kind of like a side plank from the knees, just set up slightly differently to get a little bit more at the oblique chains. But nonetheless, she was describing a lot of like tenderness on her forearm and elbow, and she's on a really good mat. Like she's on a nice like high end like MMA rolling mat. So it's not like a super firm surface. And she's describing that it's really uncomfortable when she's there, like really pressure sensitive, like achy, sore. That was 3 weeks ago. She still has a sensation of a bruise on her elbow.
That's crazy.
And this has been like, this is not the first time this has happened. It's like if she does anything that loads her system, and what's interesting now is we're kind of figuring out that she's very compression sensitive. So for example, she injured her back, very mild whiplash mechanism in a motor vehicle collision. And then she's lying on her back and literally just lying on her back with her knees bent, which for most people, low back pain is really comfortable. it's really, really uncomfortable for her. Like just the pressure of the mat on her low back is really painful. And the fascinating part is not only is it achy and sore while like really uncomfortable when she's lying on it, but if she lies on her back on like a firm surface for even like 5 minutes, it will ache for the entire day and sometimes for more than a day. That's a very unique nervous system, and you just simply can't interact with that in the same way that you would someone else that doesn't maybe have that genetic predisposition towards a nociplastic pain mechanism. So yeah, there's just such amazing variability in the people that we see, that you just keep on learning by the patients that feed you knowledge by virtue of their unique presentations, that they come at you with,
Yeah. Just a quick pause to share something exciting. I've been working behind the scenes on a tool to make prescribing home exercises easier and faster for PTs. It's built based on feedback from therapists who have told me they are tired of clunky search tools, limited customization, and complicated sharing. I will be sharing more soon, but if you're curious and want early updates, you can join the interest list using the link in the show notes. All right, let's get back to the conversation. And I think it's very common, like when you said, like, I think therapists in general, they have their niche and they are really good about, learning one technique. And a lot of times that's what they do. And I think it's super cool on your case. Like, I think your background as being a personal trainer before being a chiropractor really helped you with the exercise background, right? Because I know you do use a lot of exercise. So it's not just adjustments or manual therapy or some things that maybe other chiropractors would, use more than what you do. So I think that these variations make your skill set very unique. So I'm interested in learning more about, um, so how, um, what techniques you study, what did you learn, what different approaches you use, because I assume it's a mix by what I've listened about you and research. So I know you do a lot of different things and have like a different skill set. So just curious to ask you a little bit more about that.
So what individual like technique systems have I been exposed to throughout my career? And
Yes.
yeah. So when I was personal training, I also assisted for a chiropractor who is one of the earlier like kind of active release practitioners in Victoria, where I live. So I was very familiar with soft tissue techniques and active release technique from a very young age. I did those courses before I even finished school. As I mentioned, by the time I was done school, I think I'd already organized, over 30 courses. It was like 18, 8 and 4 plus the year prior to school. So, in those courses, Stu McGill had come out. He taught for me several times. Clayton Skaggs, who has the background with the Prague School, but also active release and very eclectic practitioner, worked with several professional athletes and sport teams. Was with the Cardinals for some time. Jack Miller with Mulligan taught several courses for me. Gary Jacob was a chiropractor. He was actually the first certified practitioner of McKenzie technique. He actually taught for McKenzie. I think he was the first North American to actually be credentialed to teach McKenzie, and this was a long, long time ago. He had also done very eclectic and varied courses of the years. So he had gone through all the Mulligan's courses, stuff like that. So he taught for me a course that was McKenzie-like, but he also bridged in like Mulligan and other things into his course. So he taught for me several times. Chris Powers, taught for me a few courses. Greg Lehman, Laura Mosley had been out and taught for me a few times way back when. So yeah, just a really, really broad, eclectic, sampling of different courses over the years. And that's just, probably 10% of the people that I've worked with. And Dale Buckberger was a huge mentor of mine. He's not so much on the speaking circuit anymore, but he was a lot, especially he was faculty at New York Chiropractic College as he was working with the Blue Jays and had his own practice, but also going to school for his physiotherapy degree. So he's a DC PT. And he kind of inspired me in a way. I guess in part filled my bias, but he was exceptional at applying manual therapy and exercise together. So manual therapy from like soft tissue techniques to joint mobilization and manipulation, and then a comprehensive exercise approach as well. So he was an outstanding mentor in the sense that he just did those three things exceptionally well. So I learned a lot from him as well. Yeah. And then, Michael Shacklock has been a massive influence over me. Shacklock's stuff is, with Neurodynamic Solutions is really interesting because I would say most people kind of feel like they know neurodynamics. They might even not know the word neurodynamics, but they were taught the straight leg raise and the median neurodynamic test or upper limb tension test. And they kind of feel like they know what like a sciatic nerve mobilization or flossing is. And I kind of felt like that when I went in to take Shacklock's course for the first time, which, frankly, initially it wasn't very intriguing for me because I kind of thought I knew a fair bit about that stuff. And I realized after taking his first course that I really didn't know shit about that stuff. So, his stuff has been just a massive like revolution in how I view and diagnose musculoskeletal conditions, in the sense that the specificity in which he applies interventions for different levels of patient presentation. So, for example, level 1 being like acute, irritable, significant compromise of nerve function. Level 2 being kind of like the standard patient with like a milder or moderate presentation, like intermittent episodic pain. And then level 3 being, very intermittent pain that's only provoked with a significant amount of exposure. And honestly, I feel like, most practitioners like me when, or before I had taken Shacklock's work, do a decent job at level 2, but do a really poor job on level 1 and level 3. In that they don't really know how to deal with a level 1 presentation because they don't understand the fundamental underlying mechanisms that drive that presentation. And level 3, which most people don't even diagnose because they don't realize it's a nerve related problem, and they just diagnose it as like a rotator cuff problem or tendinous elbow or plantar fasciitis or Achilles tendinopathy, or, in one patient who literally was en route to getting a knee replacement surgery. She was diagnosed with a patellofemoral osteoarthritis and a meniscus derangement. And, after years of going through this and being highly disabled, finally, it came across my path, and it turned out to be just a really, really nasty piriformis syndrome that so happened to predominantly impact the genicular nerves. So she had really bad knee pain that was primarily provoked by walking, going up and down stairs. Like she couldn't even walk a block. So anyway, she's now, far from when I saw her, like she's now playing adult women's rugby, like she's 100% rehabilitated. She never had a knee problem. She just had a knee on MRI that showed degenerative changes in her meniscus and her patellofemoral joint, but she actually never had a knee problem. So had I not taken Shacklock's work, to be honest, I don't know that I would have caught that. And I just had a patient, to be honest, now at the point where it's every week where I'm catching a patient that I probably otherwise wouldn't have caught as having a nerve-related musculoskeletal pain, where I would have previously just diagnosed it as a tendinopathy. Plantar fasciitis, Achilles tendinopathy, super common, that there is a neurodynamic component to that. There's some research to indicate that plantar fasciitis, for example, and this would be a low end estimate, that somewhere around like 35% of patients with a confirmed diagnosis of via ultrasound of thickening and inflammation of the plantar fascia that is consistent with plantar fasciitis also have a nerve conduction study that confirms a medial calcaneal neuropathy. And that's with ultrasound confirmed plantar fasciitis. So then you have to imagine like those who don't have ultrasound confirmed plantar fasciitis is probably a higher number. So there's a significant percentage of people out there who have the characteristic presentation and exam findings of plantar fasciitis who have a neurodynamic component to their chief complaint pain as either a primary driving mechanism for that pain or at least a confounding factor. And my experience is it's often primary, or if not primary, the confounding factor of having a secondary neurodynamic problem related to plantar fasciitis. If you don't address the neurodynamic problem, the plantar fasciitis won't get better, because as long as that nerve is inflamed or irritated, it's going to create the neurogenic inflammation that then affects the plantar fascia. So you can do all the loading you want, but if you don't address the nerve, it's just going to come right back. And again, in retrospect, for sure, many of my patients back over the years who were like slow or non-responders in the realm of tendinopathy were probably neurodynamic in nature. An area that's of increasing interest of late for me is, like frozen shoulder. We don't really have an understanding of what causes frozen shoulder. We know that there's, risk factors for frozen shoulder. We understand the pathophysiological mechanisms of frozen shoulder, but we don't know what causes the pathophysiological mechanisms. Like, what is it that causes this essentially autoimmune response that for some reason specifically targets the coracohumeral ligament in 100% of frozen shoulder patients, and then to a degree, other portions of the capsular ligamentous structures as well. Why? Like, why does inflammation target those tissues? And so you could call it random, but it seems odd that it would be random, doesn't it? It's probably not. There has to be some underlying mechanism. Well, in the last few years, I've had a few patients present. Again, I wouldn't have discovered this without Shacklock's work, that there are some patients with frozen shoulder who have an obvious and overt reproduction of their symptoms with neurodynamic testing that does not move their shoulder. So in those patients, I have found that when I very specifically treat the neurodynamics or the neurodynamic component of the chief complaint pain, they get a lot better, a lot faster. So I think that there is a diagnosis of neurogenic frozen shoulder that is probably underdiagnosed. And the only way you would figure that out is to have the skills of, doing very specific neurodynamic testing to weed that out, right? I have a patient right now, which I can't speak to the end story yet, but she has had 5 cortisone shots over the period of 2 years. She has never responded to a single one of them, and no one has thought twice to reconsider the diagnosis. And the crazy thing is, so she just got an MRI, and the MRI unfortunately has resulted in her discontinuing care with me, because in the MRI report, it says there's edema in the rotator interval. And the radiologist made a note, it's a true note. He says these findings can be seen in frozen shoulder, which is true. However, that's very timing specific. You don't see edema in the rotator interval 2 years out. You see a thickening of the coracohumeral ligament and obliteration of the subcoracoid fat triangle. So it doesn't make sense that there would be edema at 2 years. Now, what are the other findings? Well, there just happens to be a tear in the upper fibers of the subscapularis. Where is the upper fibers of the subscapularis? In the rotator interval. So, and she also has signs of tendinopathy in the supraspinatus, also on the anterior edge, which is also in the rotator interval. So she's got a lot of inflammation in her subdeltoid, subacromial bursa, and in that rotator interval. The question is, what's driving that inflammation at 2 years out? She's not moving her shoulder. It doesn't make sense that she would have an active inflammatory process secondary to a rotator cuff strain or tendinopathy at this point, because she's literally holding her arm by her side the entire time. Well, she has overtly obvious reproduction of her chief complaint symptoms with neurodynamic testing. Now, here's the flip side. If you ever seen a pain diagram of people with different shoulder pain presentations, so tendinopathy, tear, impingement syndrome, which essentially is just a tendinopathy, maybe with a little bursitis in there, AC joint, frozen shoulder. And if you look at the different labrum tear, if you look at the different like pain diagrams, in the literature, like where these different clinical conditions present in terms of pain distribution and quality, frozen shoulder often creates pain that radiates down the arm to the hand, and they often will report pins, needles, or tingling sensations in the hand. So you got to think to yourself, is that actually the frozen shoulder doing that, or did they actually just have a neurodynamic component to their frozen shoulder? Or that might be one of the primary underlying mechanisms of why people get frozen shoulder. So she has pain that radiates down the C6 essentially, or call it C6 / lateral cord. So it goes down, posterior lateral forearm into like the thumb and index finger. And when she provokes it, or at nighttime, she'll get like pins, needles, and tingling into her thumb and index finger and in her forearm. She gets a sense of heaviness down her arm. The pain radiates kind of through the posterior lateral shoulder down to her deltoid. What innervates all of these areas, or what is the common innervation between the rotator interval, the posterior lateral shoulder, and the lateral arm down to the hand? Well, the answer is, I just said it, it's the posterior cord, and the posterior cord derives the upper and lower subscapular nerves and the axillary nerve, as well as the radial nerve. Okay, so the upper subscapular nerve feeds the rotator interval. Okay, and then you've got the axillary nerve, which obviously feeds the anterior, inferior, posterior, inferior, and posterior component of the joint capsule, as well as the deltoid, and sensory innervation over the superolateral aspect of the arm. Okay, and then from there, you get the radial nerve that continues down the arm and feeds the lateral aspect of the forearm down to the thumb. So to me, like, this fits so perfectly with a neurodynamic dysfunction that's causing her pain, but no one is evaluating this. Like, no one's even doing an exam. They just say she has really painful limitation of range of motion. What were the other findings? Well, her capsular mobility is normal. When I do passive range of motion, so if you have someone 2 years out in a frozen shoulder, their range of motion is really messed up, right? They have extremely limited capsular range. So you might be able to take their arm like up to, say 70 to 90 degrees of shoulder flexion, and only at the end range do they start to experience pain or discomfort. 2 years out, non-inflammatory phase, right? And when you're taking that shoulder through a passive range of motion, because the capsule is so screwed up, the glenohumeral glide is very abnormal. So the humeral head essentially can't drop down and back because it's stuck up into the rotator interval. So the humeral head is essentially getting driven anterior superior as you're raising the arm into elevation. Doesn't happen in her. The glenohumeral glide is normal. And the reason why I need to stop taking her shoulder further into shoulder flexion is not because I feel a capsular infield. I feel literally like a twitching response. Like the muscles are contracting to block that range of motion. And then immediately after twitching, she starts to then get like a pretty sharp radiating pain that goes down her arm. So if you put all those exam findings together, she does not have a standard, a true frozen shoulder. Mm. Yeah, she just has extremely painful range of motion. Therefore, she can't move her arm. I highly suspect that if you were to put her under a general anesthetic, she would have normal range of motion. And I remember years ago, Jeremy Lewis had taught for me a couple times. And in his course, he talked about a few patients that he had seen in which, when those patients, frozen shoulder diagnosis, when those patients were under general anesthesia, so they sent them to a surgeon was going to do hydrodilation, right? But once they put the patient under a general anesthetic, the range of motion was normal. So there was no indication to do hydrodilation. So basically, my suggestion would be that that's probably the patient with a primary neurodynamic component to the frozen shoulder. And there's really nothing to say that the frozen shoulder, even if it does present like typically, wasn't initially driven from some neurodynamic mechanism. It's possible. It's possible that the neurogenic inflammation that's created from that pathology is creating the immune response in the coracoidal ligament, the capsule, et cetera. But I won't go all in on that. I'll just say that there seems to be a percentage of patients who have a neurodynamic component to their frozen shoulder that if you don't address it, it's going to be really hard to resolve that condition.
And I think that's the beauty of having like a diverse background, because you know how to screen patients and identify things that you would not if you have not been exposed to the neurodynamics, for example, the neurodynamics course. So I think that's the the the, the advantage of being able to screen patients and recognize patterns and then feed them with the best approach for that case, right?
Yeah, but also, I mean, beyond that, and that's all true. I think the other element of it is being humble enough to know that you don't know everything. So when a
Mm-hmm.
patient is presenting to you in terms of, history and exam findings, but sometimes that can be misleading. Like sometimes the history and exam findings are kind of consistent with plantar fasciitis. You're like, okay, I think this is plantar fasciitis. Neurodynamic testing is like kind of equivocal. Nothing's screaming at me here. This just happened a few weeks ago for me. Initial presentation seemed pretty consistent with plantar fasciitis. Neurodynamic testing was kind of like borderline, didn't seem to be too significant. But then after 3 treatments, I was like, this is responding like different than a normal plantar fasciitis. So went back, reassessed, and his neurodynamic dysfunction was much more obvious and much more clear, and the pain pattern had slightly changed. It was a little bit more over the medial calcaneus and adjacent to the Achilles tendon rather than, over the medial tuberosity of the calcaneus and plantar fascia. So, you just constantly have to be kind of questioning yourself. And yeah, my intern comment the other day, she's like, it must be exhausting. Yeah, it is. It is a little bit exhausting because if you're not constantly questioning your diagnosis and your decision
Mm-hmm.
making, it's very easy to get, very content in the path that you're taking with an individual patient or with a class of patients, for example, and miss things because you're not finding the nuance within that individual patient presentation. It's like, clinical prediction rules have been super interesting and great. Arguably they've underperformed in terms of research findings, but nonetheless, super interesting and great that we thought of that idea that, hey, is there a cluster of findings that we can see in an exam that kind of funnels us into the appropriate diagnosis and treatment algorithm? Well, that's amazing. But again, that removes the potential for nuance. It removes the individuality of the patient that's in front of you. And you could see 100 different disc patients and they could all present differently. They could all respond differently. There's going to be some common themes maybe, but there's going to be individual nuance that if you're not constantly asking why, and what are the driving mechanisms of this patient's chief complaint symptoms, then you're going to miss things. So,
Mm-hmm.
yeah.
And then like, how do you go about screening patients? Like, do you have like a structure that you created that you follow? Do you follow, I know like Michael Shacklock has his own way of assessing, and if it's musculoskeletal driven, if it's, more neurological, or how do you go about that on your day to day, like based on like these so many different courses and techniques that you've been exposed. So how do you make sense of all of that, and how do you structure your assessment?
Yeah. Well, first I'll say that I'm a fan of the quote that there is no truly original thought. So I don't think, anything that I'm doing is truly original. I've just learned from a lot of really smart people and I've combined, as best I can, their knowledge and skills into my repertoire. Of course, that always comes out with an individual expression. There is no single practitioner that is going to be, the same as another. And that's great, actually. But long story short is I don't think that I have anything truly original that I do. Um, I'm a big fan of trying our best to identify the pathophysiological mechanisms that define the patient's underlying chief complaint symptoms. So I would say what I am trying to do as best possible is to best define the underlying mechanisms of the patient's chief complaint symptoms and match that with the interventions that fit most closely to those underlying mechanisms. And so, I believe that there are distinct and individually unique mechanisms behind many different manual therapies, from deep tissue massage to effleurage to active release technique and myofascial release technique and structural integration, blah, 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 et cetera. Mulligan mobilizations, graded mobilizations, manipulation, and, give me any other manual technique you'd like. They all come with similar but distinctly unique mechanisms that drive their potential for benefit. Exercise also has, very, very well defined mechanisms for how exercise influences physiology. There are different buckets of exercise, all which have specific mechanisms that underlie them. And by the way, I people say, general versus specific exercise for low back pain. What is general exercise exactly? Because last I checked, general exercise had very specific physiological mechanisms. So there's really no such thing as general exercise. If you go for a walk, there's very specific physiological mechanisms that occur when you walk. And there's also very specific biomechanics. You are engaging in repeated cycles of partial flexion and extension from an upright posture with a little bit of rotation and lateral flexion. And that's being repeated and oscillated over and over and over again, which also means you're getting rhythmic contractions and relaxations of the associated muscles around the spine and all the way down to your foot. So point being is that if you dive deep enough, you can define very specific mechanisms that even govern the process of walking. And those mechanisms align very well for some people with low back pain, right? Or neuropathic pain of the lower extremity related to perhaps radiculopathy. And in some patients, it doesn't, based off of their underlying mechanisms, right? So, point being, motor control exercise, is this just a lower load exposure that fits well for a level 1 patient that you then allow the opportunity to calm down and then grade exposure to more load over time into a higher intensity exercise, more load? Or are there specific mechanisms underneath stabilization system dysfunction and postural locomotor function that are potentially holding this patient in a pattern of chronic recurrent pain because of the way that they move? And I would argue that both could be true, that most motor control training, as has been historically defined, although 100%, I don't think that's accurate. Nonetheless, most motor control training has been low load exposures, which often is going to be very favorable for people within a level 1 presentation, highly acute and irritable. So it gives you an opportunity to create an exposure and move into higher level exercises that add more load. But sometimes it's necessary to peel down to those more like foundational layers of function to build that basic foundation for higher level exercise. And of course, general exercise, we call it squat, hinge, push, pull, carry, step, reach, etc. All of those kind of general movement patterns are also motor control training interventions. And you have opportunity actually to consider that, I could train sagittal stabilization from the ground, i.e. supine 3 months in DNS, or I could train it in a hinge or a squat or a squat stance row. Right? I could train it with a dumbbell press. There's so many opportunities to train the stabilization system that goes beyond, a clamshell. You know what I mean? Or a dead bug for that matter. Right. Mm-hmm. And they have common characteristics, but they also have distinctly unique characteristics in terms of postural locomotor function. So you've got exercise, you've got manual therapy, you have cognitive interventions, you have emotional interventions, and socio environmental factors, all which can kind of drive a patient's complaint. So, for example, back to the patient with the bruise on the forearm from the low oblique sit. Prior to seeing me, no one had ever explained to her the concept of nociplastic pain mechanisms. No one had ever explained to her that there are indeed genetic predispositions toward chronic pain, and those have now been identified. That she probably fits within that realm. We don't have genetic testing to confirm it, but hey, it seems to me like when you bump your elbow, mildly, and you feel like you've got a bruise for 3 months, like that's not typical. So you probably have something unique about your nervous system. And for that patient, that was incredibly empowering, because then she knew that, hey, the pain that I'm feeling is not necessarily a representation of harm, but if I don't move and I stay in a bubble and I try to protect myself too much, my resources get less and less and less over time. And then I have more disability and more dysfunction. My quality of life sucks. So now she kind of knows that she just moves through it. And when she first saw me a few years ago, like, her range of motion was incredibly limited. Her ability to sit down and squat was incredibly limited. She moves really well now. She still has pain, right? It's not all the time. I mean, she just had another, unfortunately, motor vehicle accident, but she still experiences frequent pain, and that's just her nervous system. But she's not limited by it. She's not depressed by it. She's not anxious by it. She just kind of understands that's part of who she is, and she moves through it. And she lives a very productive, healthy life now. So, addressing the cognitive and emotional factors that related to her presentation early on was really, really fundamental. She had poor function. She had poor range of motion. She had pretty poor stabilization patterns. Her general fitness and her strength was not good. So there's many physical factors that could relate to a nociceptive pain mechanism. But the biggest thing that was holding us up was her cognitive and emotional understanding and response to her pain. And once we address that, then we could dive into movement and exercise, et cetera. And by the way, if you have someone who's super pressure sensitive like that, do you think manual therapy helps?
I mean, I'd assume they would get more irritated maybe by compression.
It doesn't help at all. I mean, I can feel like tight muscles and a restricted joint. And I've tried, trust me, to our own fault, maybe, to do, some soft tissue work to loosen up those tight muscles. And honestly, objectively, the muscles are less tight after the treatment. She 100% feels worse every time. and it's not like short-term worse. It's like she feels bruised for like 3 or 4 days after a reasonably light manual therapy intervention. So it's just not the right treatment for her, right?
Yeah.
So overtop mechanisms are neuropathic pain mechanisms, nociplastic pain mechanisms, physiological nociceptive pain mechanisms, emotional, cognitive, and socio-environmental. So those are kind of like your top of the tier. Those are your overlying mechanisms. And then let's say you funnel into physiologic nociceptive, right? Then you've got a massive umbrella under which fits a lot of potential things, which could include stabilization system dysfunction, postural locomotor system dysfunction, kind of the same thing, but has an extension to it. Then you've got potentially just like a lack of general fitness, a lack of general strength, like poor control over range. So mobility dysfunction that might relate to they have range of motion but can't control it. That might sit under stabilization system dysfunction, but it might not. It might just be like a local segmental sensory motor control dysfunction around a shoulder that's been injured. That's not necessarily, I would call like a classic stabilization system dysfunction, which always has a little bit of a global orientation to it, but just like a local joint that's been injured and the stabilization system thrown off. So sensory motor control dysfunction. Just general lack of range of motion. You also might have underlying pathological processes like degenerative changes or osteoarthritis, You might have structural lesions like a meniscus tear or an ACL tear or a disc lesion, which, by the way, are almost always relevant in some way, shape, or form. Like the idea that imaging doesn't matter, the idea that structure doesn't matter is just kind of stupid. Like, listen, like no one has a tendinopathy with a totally normal tendon. You know what I mean? So yes, many people will have tendinopathy or tendon tears without having pain, right? But no one who has shoulder pain, which could be identified as, say, rotator cuff related shoulder pain, with nothing going on in the rotator cuff. 100% of those patients are going to have something that is functional, physiological, and structural that is occurring in their tendon. So it always matters. It's just the extent to which it matters that is meaningful for us, right? And the answer in our profession is almost always like first line of care is conservative and rehabilitative in nature. We're not jumping on surgery because someone has a meniscus tear. We're not jumping on surgery just because someone has like a partial tear of the rotator cuff, in an older population especially. Your first line of approach is always going to be, exercise, rehabilitation, manual therapy, et cetera. Nonetheless, structure always matters. So that's just nociceptive umbrella, right? So, structure, physiology, and function. Structure, physiology, and function. And then again, there's so many different potential nuances to that in an individual patient. And then you'd have to look at like the nociplastic pain mechanisms, of which you've got kind of peripheral nociplastic pain mechanisms. So, sensitization of the peripheral nervous system. And then you've got central nociplastic pain mechanisms. So sensitization of the central nervous system. And, most often you'll have both, but sometimes you'll have more one than the other. Okay. And then in some people, you're going to have nociplastic pain mechanisms that aren't necessarily the primary driver. So for example, if you have a persistent nociceptive stimulus, and that goes on for months or years, as it can in some patients, there's always going to be a degree of underlying sensitization of the nervous system in which you might not characteristically define it as nociplastic pain, but nonetheless, there are adaptations in the nervous system that make it more likely for them to experience pain in response to, for example, load, right? So it's almost always going to be some element of the equation, but it just might not be the primary driver. But when it is the primary driver, then your interventions change drastically. Between nociceptive and nociplastic, the way you interact with patients changes drastically. And then, of course, cognitive emotional domains are really just like getting to know the patient, how they respond to their pain, what they're thinking about their pain, what is their emotional response to it, and then trying to seek, a better understanding and a different emotional response. And sometimes that means a referral to a mental health practitioner, clinical counselor, somatic therapist, psychologist, et cetera, that might be able to more specifically, address that. If someone has like a history of trauma, or a history of like, generalized anxiety, these things influence physiology. Stress causes inflammation, and then you have, beyond that, by the way, it's not the only thing that causes inflammation. Shitty diet also causes inflammation, right? Poor lifestyle, sugar, if you have some kind of a dietary, it's like, I cannot do gluten. Like I was negative for celiac, but if I eat gluten, I will get eczema on my hands. I'll get a rash, and my gut will be not normal for weeks after just a single gluten exposure. I thought that I had ankylosing spondylitis at one time because I had such severe thoracolumbar joint and recurrent sacroiliitis, which I've never had again since eliminating gluten. So if you've got some kind of a dietary sensitivity,
right?
So those factors, of just a lack of movement and exercise, so if a person never exercises and they have low back pain, I'm not going to start with high detail DNS based supine 3 months. I'm probably just going to start them walking. Probably my most common recommendation for people with low back pain is that I want you to walk 60 to 90 minutes every day. I don't care how you get it in. You could do it 10 minutes at a time. You could do it 5 minutes. It doesn't matter to me. Just try to get 60 to 90 minutes of walking in a day. And then you kind of have to define what that means, because, going to the grocery store doesn't count, right? But that's the most logical starting point for a patient with persistent low back pain who never moves, right? And is that motor control training? Yeah, it's motor control training. Is that general exercise? Well, yeah, that's general exercise. Is that affecting systemic physiology? Well, of course, yeah, that's affecting systemic physiology. And what is one of the number one risk factors for like osteoarthritis or like degenerative tendons, et cetera? Diabetes, right? Like metabolic syndrome, metabolic X syndrome. So if someone's systemic physiology sucks, why would you swim upstream? If someone's systemic physiology sucks and you're trying to do like motor control exercise, you're literally trying to swim up a very fast swimming river, and you might stay, at pace with that, but eventually the systemic physiology is going to win, because no one's going to do dead bugs for the rest of their life if they're not getting significant or prolonged relief from it. You know what I mean? So systemic, physiological factors are a huge thing, and that's not really defined in like the pain mechanisms that you'll read in the literature, but it's hugely important. Socio-environmental, honestly, is probably the hardest. It is probably the hardest, because changing people's social circumstances is not easy. I remember years ago, I had a patient who had a son who was in a very difficult situation, significant mental health disorder, probably schizophrenic. And she was under incredible stress. And she had this persistent mid-back pain. And it would kind of get better with treatment, but it would never really go away. It would always kind of come back. And I just had the conversation. I said, listen, like, this is probably related to stress. I'm going to help you get through this. And I know that you get some temporary relief from treatment. So we'll give you that. But we're really going to kind of work through, the regulation of stress, so breathing exercises, meditation, et cetera. But honestly, it didn't really ever fully resolve until the stressor went away, which was when her son got the appropriate help and it stabilized. And then all of a sudden her mid-back pain resolved, and hasn't come back since. Actually, I shouldn't say that. It came back once, and it was when her son had another like flare up, like a relapse. And then she had mid-back pain for a few months, and then it went away again when her son stabilized. So, socio-environmental is tough, because, how do you change that circumstance?
It's not like on your hands, not something easy that you can just remove from.
Yeah. And the understanding of that, I think, helps a little bit for patients, because it reduces the stress. They're like, if someone has persistent pain, it's really stressful if they don't understand why. You know what I mean? So, anyone who has pain who doesn't have a diagnosis is stressed, because they're trying to figure out what's causing my pain. So when you can give them an answer that kind of makes sense, then it automatically lowers their stress. It doesn't abate the fact that they've got these other stressors in their life, but at least they can kind of make sense of the fact that, oh yeah, I am under a lot of stress. And I always say to patients, like, someone comes in with like generalized neck tightness, like, generalized tightness around their jaw, maybe they're clenching at night. I always say to them, like, one of the most universal experiences of humans is that when we are under acute stress or chronic stress, we all experience tension and discomfort in our neck and our shoulders.
Yeah,
we all
that is
do,
true.
Right? It's a universal phenomenon. So now layer that on for 3 years, 5 years, 10, like layer that on, or acute stress that's of many months in duration. Like, you're gonna feel tight. You're not going to feel great in these areas. So then you just need to learn how do you best decouple the stress mechanisms and the physical response to that stress. So like most people, I think, have a 1-to-1 ratio between stress and tension. Stress goes up, tension goes up. Stress goes down, tension goes down. And most of the time, in my opinion, that is because they don't understand when and where they're holding tension, right? So you feel stress, you manifest tension. right? They don't know they're holding tension in their body. It's just there, right? And it's just like a part of their, it's a mirror that's following them all day. It's a shadow that follows them all day, is the way that Pavel would say it. So if they can decouple stress from physical tension, it makes a really big difference. So what do you do with them? You take them through like progressive relaxation techniques, breathing techniques, so that they can start to perceive and feel where and when they are holding tension, and teach them how to unwind that tension, so that twice a day, usually is what I prescribe, twice a day for 5 minutes. I just want you to go through this progressive relaxation. And eventually what happens is almost all patients will come back to you and they'll say, you know what, I didn't realize I was clenching my jaw when I was driving. And I realized the other day, like I'm catching myself like always clenching my jaw while I'm driving, or always holding tension in my shoulders, like squeezing them kind of like up and back like this. And they just don't realize it, right? So once you can decouple that mechanism, then stress can go up, and tension is always going to go up a little bit. I think that's a normal like sympathetic physiological response, but you want it to go up on like a 3-to-1 ratio, right? Where it's not like a 1-to-1 pair between stress and tension in the body. And again, like you could have a nociceptive pain mechanism if you layer on stress, and they don't understand how to free themselves of the tension that's related to that stress. That's not going to make a nociceptive pain mechanism better. You know what I mean? It's going to make it worse. Anyways, that's hopefully that gives you a little bit of an idea for how I view things, from that kind of top tier, and how that funnels down into potential for interaction based off those mechanisms.
Yeah, and then one thing that I was thinking as you were talking about the patient being aware of that situation, I think it's the first thing. And then I was thinking about like I know you mentioned Annie O'Connor before on other podcasts, but like how they also describe like having a diary of like writing down, the patients writing down what happens when they have pain, so they start being aware of the environment and what's happening while they have start having symptoms. So I think that's also super interesting.
Yeah, pain journals are sometimes like super helpful, maybe even you could say in some cases critical, because very often I find this is especially the case with like nerve related pain, that's like higher level, like level 2, 3. There's often a delay. This is true for tendon pain too, for that matter. They might not feel a lot of pain or discomfort while they're moving, but they will have more pain that night or the following day. But because it's not happening in the moment or immediately afterwards, they don't understand the relationship. And so they never kind of figure out what is provoking their pain or their symptoms, and what is easing their pain or the symptoms. So how many patients do you see who walk in and you say, well, what aggravates or increases your pain? I'd be like, I don't know. Well, what makes it better? I don't know. I guess lying down makes it better, but then it's worse at night. I don't know. They just don't really have a true awareness of provoking and easing mechanisms. And that's critical. Like if they're, via their work or their daily activities, doing something on a repeated basis that keeps on, sensitizing this pain mechanism, whether that's nociceptive or not, it's going to be really difficult to get over that diagnosis. So.
Yeah, no, absolutely. And then just another comment when you were talking about inflammation. I remember on my interview with Dr. Peter Bruckner about sugar and the knee, he was doing like research and studies about the influence of sugar on knee pain. And I thought it was super interesting.
Yeah, man. Yeah, again, swimming upstream, you're not gonna win when you're swimming upstream. So for me, when I'm seeing, like, first of all, my hidden goal with pretty much every one of my patients is to get their lifestyle into a state, whatever that means for them. There's tons of variability in this, but at least try to get them moving on a regular basis, 150 minutes of cardiovascular exercise a week, 2 strength training sessions, a little bit of daily mobility and stability based work. Let's just try to trend you in the direction of just being generally healthy. And I think one of the biggest mistakes in rehabilitation, I think it's a myth of rehabilitation, is that you do rehab to rehabilitate injury versus restoring optimum health in the person. And I think, listen, like, no one likes doing clamshells. No one likes doing external rotations with a band. No one likes lying on their side and with a dumbbell. No one enjoys this exercise. No one likes it at all. So why not start from the premise of what is just healthy exercise? What are just the optimum health habits that we could cultivate in a patient? And then kind of trend in that direction. So instead of being like super focused and specific of like, okay, I'm going to rehabilitate this tendon, why not start from, well, how can we rehabilitate this tendon in the context of restoring optimum health in the person? So that's why, if you have a level 1 patient with a supraspinatus tendinopathy, why not start with pulls? Why not start with deadlifts, squats, lunges, and a split stance row, right? You could do a goblet squat. Goblet squat is isometric loading and shoulder flexion. A little bit of co-contraction around internal and external rotators. You got to hold the bell and you got to hold it up. So external and internal rotators are co-contract and stabilize the shoulder in a shoulder flexion mechanism. It's usually or almost always pain-free, but you are loading the shoulder. Deadlift, what are you doing? You're loading the shoulder. If you put them into like a single arm front rack position, right? If they can hold that position and do a lunge, you're loading the shoulder. This exercise, if you hold this long enough, your rotator cuff is screaming at you, right? But it's a very safe position to load the rotator cuff. And then do split stance row. Train the legs, get a physiological response that is systemic in nature, which is, by the way, analgesic, right? General exercise is analgesic in nature. So why not take advantage of that endorphin and analgesic mechanism? And then when you're doing a pull, you are more anterior cuff than posterior cuff. So it's relative unloading of the posterior cuff, which is your irritable level 1 bit, but you can still load the shoulder as a whole. And by the way, a lot of people who have poor shoulder control are going to pitch the humeral head forward and anterior when they do a pulling pattern. So find specificity in controlling the axis of rotation around the glenohumeral joint while you're doing a pulling pattern. Then you're teaching optimum control, i.e. motor control of the shoulder that could preface them into training specificity of the tendon with reaching or external rotation mechanisms, right? Why not do that? And then you're building health habits that also rehabilitate their shoulder. And patients will ask me, be like, so how long do I need to do these exercises for? I'm just like, well, how long do you want to stay healthy for? Like, like, yeah. Listen, like I put at least, I would say on average, an hour into my body every day. And that's a combination of cardiovascular, mobility work, stability work, strength training, right? And that is just normal. I.e., that's what is normal for human health. So people are coming in thinking that you're going to fix their problem. And you're going to fix their problem by doing a couple treatments, getting some targeted exercises that they're going to do for 3 weeks or 6 weeks or 3 months. And then they're going to stop doing those things because you fixed their problem, right? That's a huge mistake, right? What is the number one risk factor for injury? Any injury, a prior history of said injury, right? So why would you think that you can just stop maintaining your body because you've restored or rehabilitated an injury? But I think a big part of that is because we're approaching our patients in this rehab mindset. We're just going to rehabilitate this shoulder rather than saying, I'm going to restore optimum health and function in the person. Right?
Yeah, no, it makes total sense. Absolutely. Sometimes, it's the patients come and have that in mind. I want to do these exercises for a few weeks and that's it. And then they don't change their habits or nothing at all. So, it makes total sense. And I wanted to ask you something really quick. I know we've been talking for a long time. So going back to the nociceptive mechanism, and I know you as a chiropractor, you have a strong manual therapy background, and we are talking a lot about exercises as well. So like, when do you choose to use manual therapy or exercises, or you use both usually? Also, I was just curious to ask you about that. How do you use that on your practice?
That's a good question. Let me start with when I prefer not to use manual therapy. I prefer not to use manual therapy, especially in the front end of an interaction with a patient. So talking like the first maybe 2 or 3 weeks. In patients who have an obvious lifestyle related dysfunction of that's connected to their injury. So significant lifestyle factors, very deconditioned, and some kind of like sensitization. So what I don't want to do in those patients is I don't want them to think that I am the one that's going to fix their problem. So my first step is, if someone tends to be like a passive coping mechanism patient, where they're just like seeking someone else to fix their problem rather than kind of engaging in the process and being part of the solution or fixing it on their own, I would much, much rather delay manual therapy until we've done, 4 to 6 sessions in which they have fully understood and comprehended that they can modify their own pain experience, right? They need to know that they can change their pain. And they also need to know that they can just generally feel better when they exercise, right? Once I have that foundation, I've got a series of exercises. Usually by the time I'm 4 sessions in, usually my patient has been given between 4 to 6 exercises. And again, this could be like squat, hinge, push, pull, not necessarily totally specific. I'm just getting them moving, and there's an element of specificity for their individual problem, right? So once I'm there, and again, I'm constantly reevaluating every single session, right? Once I'm there, if I'm like 4 to 6 sessions in and I'm still seeing a movement pattern dysfunction that connects with some functional / structural limitation of their tissues, or of their joints, then I am going to go in and perform manual therapy to try to open up or get better access into that movement pattern, right? So it's like it's definitely easier to change movement with manual therapy temporarily than it is for exercise, because exercise requires perception, right? The patient needs to feel the difference in their movement to be able to practice and interact with it. Manual therapy is like almost like a quick fix, but the problem is it doesn't last, right? It doesn't stick.
Yeah. And they get dependent on that.
Yeah. Well, that's the huge problem, is that if you started that interaction with a passive coping patient with manual therapy, and then you try to do exercise with them next, they don't really want to do it.
They're not going to want it. Yeah.
The compliance goes way down, because they're just like, well, why would I do these exercises when I don't really want to do exercise, when I can just come in and get a treatment? I'm just like, well, because I want you to fix your own problem, and I want longevity, right? I want layering and progressive improvement over time, not just like a 1 week gain from a manual therapy interaction that then subsides from that, right? So that's one context. The other context would be someone who does not have passive coping mechanisms. They are active to begin with. They exercise on a regular basis. They're coming in because they've overloaded, tendon X, Y, or Z, or they've got mechanical low back pain related to, overuse or some specific mechanism. In that patient, I have no apprehension to open the window of opportunity for better movement and function in their exercise. Right. So in those patients, I probably am going to do like 5 to 15 minutes, depending on the patient, manual therapy intervention, which is always going to be some combination of soft tissue techniques, joint mobilization, potentially manipulation. And then that ties directly into the movement pattern dysfunction that I'm trying to get at. Right. So, if when a patient's raising their arm, they can't get out of this mechanism where they're kind of excessively anteriorly tilting or downwardly rotating their scapula, I might do work in and around the shoulder girdle, neck, and mid back to get a better like uprighting response through the cervical thoracic spine and shoulder girdle, and then do an exercise that taps into that same mechanism. So your manual therapy and your exercise should always essentially have the same fundamental purpose, right? you're not just randomly like adjusting or releasing things. I think this is probably commonly understood, but if I see thoracic extension as being the primary limitation in a person's neck pain, which often is the case, right? If they cannot extend, rotate, or laterally flex from their upper thoracic spine or upper part of the rib cage, then those mid to lower facet joints and intervertebral discs are going to be under a lot of stress when they look up or right or left, right? So we need to get a better functional foundation for the neck by treating the thoracic spine, right? So I'm going to do mobilizations. I'm going to do manual therapy, soft tissue, and manipulation for the upper thoracic spine and rib cage, as well as the shoulder girdle, because that's part of it. And then I'm going to do a specific exercise intervention that taps into that uprighting response. Yeah, better uprighting of the cervical thoracic spine and shoulder girdle to unload the mid to lower cervical spine in extension, rotation, lateral flexion.
Yeah, so it basically whatever makes them to move better, whatever makes it easier for them to, improve their range of motion, or, whatever need to use in that moment to make that happen, and trying to not make them dependent on you or in passive modalities, trying to be as active as possible, but then using if needed in specific situations to, help them improve quicker.
Mm-hmm. Yeah.
Yeah. Okay. Well, we could discuss a lot more, and I have probably a lot more questions, but just generally, like, what do you think you use the most? So like for clinicians that are listening to us, you study so many different things. So I know it's hard to say one thing, but what would you recommend clinicians do? Do you have any advice in that sense? Do as many courses as you can, or, is there something that you recommend in particular or anything?
Yeah, you're talking about like education that can facilitate,
Yes.
Yeah. Well, I think there are, learn as much as you possibly can from as many people as you possibly can. But there are certain foundational courses that are so essential that if you don't take those courses, your view of human movement, for example, changes dramatically after taking DNS. Like your understanding of how postural locomotor function works via the developmental process is, I think, really essential to understanding the human movement system and therefore how you interact with it. And honestly, it just catapults your learning in clinical practice because all of a sudden you're seeing things that you would never have seen before. And like DNS has an exercise model, i.e. we can engage in developmental exercise to engage motor control changes. But you don't actually need to do developmental exercise to change motor control. And we fully acknowledge that. What we're really trying to drive towards in DNS is a better fundamental understanding of the neurophysiology of human movement. Okay, so that DNS to me is foundational, and then neurodynamics is also so foundational. Now, unfortunately, my answer to this question is a little bit biased because I was already so rooted in strength and conditioning, human performance, personal training, correct, all of that stuff. So I already had that from when I was a kid, basically. But DNS and neurodynamics being foundational in terms of being able to actually discern whether or not you actually have a nerve problem or knowing how to interact with a level 1 problem, critical. DNS in terms of like your lens for human movement, essential. But for those people who do not have a background in strength conditioning, you should take a course with a good strength and conditioning coach. Go see Mike Robertson or Eric Cressy, or go to a conference like a Perform Better conference, Charlie Weingroff. Like, go learn from someone in this space of strength and conditioning. Because I got to be honest with you, there are some strength coaches, and for that matter, personal trainers out there who are doing a way better job of rehabilitating injuries than physios and chiros are. because they understand general movement and function better than the physio or chiro who's just nailing out like abdominal hollowing and external rotation. You know what I mean? So I think that's a really important part of the equation. And to be honest, I think one of the primary things that determines whether a person prescribes exercise in their clinical practice and how they prescribe it in clinical practice is whether they exercise themselves. So if you are not currently living a healthy lifestyle, as we have international definitions for what that means, then maybe the first step is for you to take care of yourself and to engage in healthy habits around cardiovascular, zone 1, 2, 3 exercise, strength-based work, mobility and stability-based work, movement pattern training, all of that stuff. Because it's the exploration of movement within your own body is very informative for how you work with people. And, unfortunately, I'm going to speak to those who move really well out there. People who function really well do not understand what it's like to not function well. So when I see someone talking about like motor control training as if it's like meaningless, there's no point to it, everyone moves in a variable ways, just load the body, blah, blah, blah. But they've never actually gone through significant postural locomotor dysfunction that has been connected to an injury. I just find that incredibly narrow-minded. And if you move really well, you probably need to open your mind up to the fact that some people don't. And, if you refer to like the research and developmental world, approximately like 20 to 30% of infants don't go through like optimum development of postural locomotor function. Now, there is a big percentage of those infants with a very mild, what we call central coordination dysfunction, that likely, find optimum function through practice and experience. Okay. So usually in those babies, you'll see, maybe at 5 months, they're not rolling both ways, or when they roll one way, they kind of go into like an open scissors pattern where they're not controlling sagittal stabilization through their turning mechanism. Usually that relates to, a preference to roll one side versus not the other, or maybe they don't ever roll to their left. They only roll to the right because it's much easier to do that. So in some babies, that's an incredibly mild deficit, and a very like brief exposure to getting them to turn over sagittal stabilization very quickly restores their optimum function, or they just practice. And maybe it's like 7 months when they get left turning, right? So in other babies, where you're talking like more, moderate central coordination dysfunction, which by the way, these babies are not treated generally. In North America, we're not treating these babies. No one is going in and really working on these things because we have a very quantitative approach to our infant assessments. In other words, if the baby can roll over, it's a check the box. If the baby can stand or walk, check the box. And you just have like time frames for these milestones, right? But in Europe, especially Eastern Europe, they have a quantitative but also qualitative approach to their assessment, where they're not just observing whether they can do it or not, but also the quality of that movement, right? So, I'll give you an example that we give in the DNS course. Is a young girl, was seen in Prague at a very young age in infancy, and that's normal for them. They do these assessments in all babies. And they actually recommended treatment early on because she was showing signs of moderate to severe central coordination dysfunction. The family, unfortunately, was moving away. So they didn't get any treatment initially. They came back a couple of years later with a little bit of concern because they were seeing some things in her movement that they were a little concerned about. Anyways, they evaluated them again, recommended treatment. Unfortunately, they weren't again living in Prague this time, so they didn't get treatment right away. And then at 4 years, they came back and they were actually moving back to Prague at this point. The baby, or the young girl, I guess at this point, the toddler, roughly, yes, 4 years old. She was now developing a scoliosis. And she had very clear like sensory motor control dysfunction. And she also had some like visual dysfunction as well. So, that's more like moderate to severe, but there's also slightly milder case in that. In other words, like not everyone develops the same. And some people never have the optimum software installed into the system.
Yeah.
Right. And for folks who are the 70%, and don't necessarily understand that, don't feel that, don't experience that in human movement, they just kind of sometimes don't get it. They don't understand that, someone else maybe can't stabilize their lumbar spine. They don't have the fundamental prerequisites, and you can't just like deadlift them and squat them into success, right? You actually need to go back and engage more fundamental patterns of stabilization. I don't even know how I got on this topic, but you were mentioning
Advice to the
yeah.
clinicians.
So DNS, neurodynamics, and then, like I said, if you
Strength
don't have
conditioning.
if you don't have any background in strength conditioning or personal training, like dive into that space a little bit.
Mm-hmm. And then I know you teach some courses on your website. You have some blogs and you have a YouTube channel. So then in general, if people want to learn more about the topic and then learn about you, how they can find you and more information about, that you recommend, that think it's a good resource for them to go check it out.
Yeah. I try to pump out an article at least every month on my blog. I hope they're informative for people. Sometimes they're very detailed, and encapsulate, dozens of studies that I'm kind of summarizing with my own kind of perspective. Other times they're just kind of like random thoughts of the day that I feel like writing down. My YouTube channel has a fair bit of stuff on there. It's probably definitely more active producers of content there. Bo Baird, who I did the podcast for, his YouTube channel is great for like looking at DNS related work. In terms of like coursework, primarily these days I'm teaching for DNS, Prague School in DNS, and Shacklock with his neurodynamic solutions. So every year I'm teaching somewhere between 15 to 25 courses and conferences. I do have an online shoulder course that I produced in, I think that was 2016, 2017. I think it's very foundational in nature. It's very detail oriented. I'd probably, do it a little bit differently if I were to do it today in terms of like the depth that I go into some exercise, but I think that's probably more like module 2 that we're looking at, which I actually did teach a module 2, which was called Mastering the Shoulder in Clinical Practice, which was a layering of the level 1 kind of foundational course that's featured online, and then going through like a clinical case focused course on the shoulder. So yeah, primarily teaching DNS and NDS work, and occasionally teaching on specifically the shoulder. So yeah.
Very cool. And then your website?
Yeah, it's just drmichaelmaxwell.com. So drmichaelmaxwell.com.
Mm-hmm.
Yeah.
And you have social media as well?
I do. I'm not overly active on it, but again, I'll sometimes get inspired to put down my rumblings of the day on there. Yeah, my weekly rant. My associates know that at least once a week I'm going to have a little hissy fit in the staff room about the unfortunate circumstances of a patient exposed to incompetent care. So sometimes that lands on my social media, but yeah, but obviously I love engaging dialogue with people, and I love learning, and we learn by interacting with each other. So by all means, connect with me on Facebook or Instagram. Like I said, I'm not crazy active, but I'm there. Yeah.
Very good. Very good. Any final thoughts before we wrap up?
No, not really. I hope you guys get something out of this. And yeah, maybe we'll come out to Bermuda for a small course one day.
Yes, that would be great. Yes, we have to talk about that.
There's I think he was a chiropractor who I met. I think he was a chiropractor, but I'm not 100% sure. He was at the Prague DNSD course when I was there doing my instructor's course several years ago. And he was from Bermuda.
How random. Bermuda
Yeah,
is such a small place.
yeah. I mean, I don't know if he's still there, but I think he was from there. Like, so in other words, like been there for a long time. And I don't want to say his name was Mark, but anyways, he would be on the DNS website. So if you ever want to connect with people in that realm, I think he's in your area. Very, very keen guy, very eclectic and broad background of knowledge. So yeah, anyways, but maybe we'll come out there and do a little slash teaching slash holiday. Yeah.
Yeah, get together all the healthcare providers here and see if you can make one class.
You guys, I would imagine like almost all of you guys need to travel to go to courses, right? So
Yeah,
yeah.
mostly. Yeah.
Okay, well, thanks so much, Mariana. And again, hope you guys enjoyed this and hope your listeners get something out of it.
Yes, thank you so much for taking the time to come chat with us. So I appreciate it.
Yes, you're welcome.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.